All right, everybody. So, actually, this is nice having a smaller class, so feel free to ask any questions as I go. Feel free to interrupt. I'm much more prone to conversation than lecture, so please do that. Today, we are going to be talking about, what are we talking about? Capacity planning and scheduling and forecasting. And you have already had a bit of a lecture in this.
Talked about
to some degree?
We just did the beer game not too long
Did the beer
ago in
game.
one class, and I think the other class has done their capacity planning and scheduling budget.
Okay. And have you done any case studies on forecasting a little bit? There was one
Not
last time.
specifically.
So, if you were taking an MBA class with some of the most clever business minds in the world, and you were reading a case study, and you were looking at how to improve your profits and all this kind of stuff, you would notice that all of your peers in the first piece of their case study write-up say, predictions need to be better. That if we only knew better what was coming and how much demand we would need and what the lead time would end up being when we're shipping things across the planet, then we can better design our system. And while that's a true statement, it is often kind of pointless because obviously if you knew everything that was going to happen, you would design a perfect system. So with that said, forecasting is really important. It's the thing that will enable you to design an amazing health system. If you knew globally exactly how the population was going to grow, exactly how certain diseases are going to spread, and exactly how everyone is going to react to a certain intervention, whether it be needle exchanges or flu virus vaccines, all these sort of things that require some very complex models. If you had perfectly predicted models, you would be able to make some of the most amazing changes to the world. Unfortunately, it doesn't work that way. There are limitations to forecasting. And so what I'm going to talk to you a little bit about is forecasting, how it's done, give you some examples. My expertise is in hospitals, looking at patient flow and looking at capacity planning in hospitals. So I'm going to talk to you a little bit about that, a little bit about just the dynamics of forecasts, and just hope to have a little bit of a conversation with you about it. So does that sound good? Throughout the lecture discussion thing, I'm going to have these little clouds. This is a sign that I'm going to sit still until somebody says something. All right? And since we have only an hour, you would only be cheating yourselves from brilliant material by not continuing the conversation from there. Okay? So let's move. So I'm going to put a stake in the sand and say that the goal of most healthcare product organizations are to make money. Many of them will say, well, we're really just creating products that heal the world, but they want to make money. And then the goal of most healthcare delivery organizations is to provide quality care for a lower cost. And I would argue that public health organizations, if they're nonprofit or work for the government, have a similar goal as the healthcare delivery organizations, that they are trying to deliver quality care for lower cost. If we have a population of people who we are trying to decrease the spread of bloodborne diseases due to drug use in the country, how do we get the biggest bang for our buck? What policy can we do in order to decrease the spread of this disease for the least amount of money? Is it education? All these things. Their goal is best care, lowest money. And so why do we forecast? I discussed this a little bit. We want to minimize excess inventory and staffing. So if we know how many needle exchanges we need to do to be optimal, then we can know how many trucks to send out. And if we know how many trucks to send out, then we know how many people to put in those trucks, and we know how many needles we need per truck. And you don't want to put out too many trucks because that costs extra money, and most governments right now are broke. And you also don't want to have too few because then you lose sales opportunities and you lose treatment opportunities. And when you are dealing, especially with something like a disease that has some sort of threshold that once you cure a certain amount of people, you get that sort of herd immunity where it's not spreading anymore. If you miss a certain number of opportunities, you might actually completely undermine the entire project. And so forecasting becomes really important for making that decision. Cool? Any thoughts on that? Have I grabbed your attention? Excellent. I got one nod. I'll take it. So, how do you use forecasts? So I break, in my mind, there as having 3 dimensions of forecasting. The first is how you're going to use the forecast. The second is what goes into the forecast. And the third is the guts of the forecast, the actual technical model that you use to make your forecast. And so when we talk about use, I tend to use forecasts on a clinical or operational level. And I'll talk about each one of these in more detail in a moment. You also have use in terms of time frames. It might be a long-term forecast or a short-term forecast. Are we looking into tomorrow's demand, or are we looking to 10 years from now demand? Bless you. So, for example, right now at the VA, I'm working on a project on how we optimally shrink our services, because currently the veteran population is shrinking, assuming our forecasts are correct and we don't have another major war and suddenly more veterans come in. But we have to figure out exactly how much capacity we need in the New England network in order to manage this sort of decline of veterans. And right now we have a little bit of a surge, so we have to do a short-term forecast in terms of how much resources we need next week. But then we have to do a long-term forecast 15 years from now. And the two have to balance out, because if we invest too much now, 10 years from now, a lot of that infrastructure that we build would go to waste. So you also have the input, which can be endogenous or exogenous, and I'll talk about those a little bit more in a minute. And then the guts. There's a lot of different techniques for making predictions. Some of you have probably heard of them: data mining, artificial intelligence, statistics, and computer learning. As a non-expert in any one of these things, I tend to be an applied forecaster as opposed to an academic forecaster. I would argue that they're pretty much all the same to me. But a computer scientist over at MIT would see me do that, say that, and then would want to punch me in the face. And so I will, out of reverence to them, I will explain a little bit of a difference between all of them. Fortunately, they just sit at their computer all day, so their hand-eye coordination might not be good. So, if we talk about resource allocation, and I mentioned one example is balancing the overuse, the over-ordering of resources or the under-ordering of resources. And there's a classic model in operations management called the news vendor problem. Have you gone over the news vendor problem? Awesome. So, through some actually very good, high-quality math, they've come up with this equation that basically says that when you want to order a certain quantity, and it comes from, I should use the news vendor example. You are a newspaper vendor, and in the morning, or maybe the day before, you order a certain number of newspapers to sell throughout the day. If you order too many, you end up with extra newspapers because that news becomes obsolete the following day. If you order too few, you lose the chance to sell. You have an opportunity cost that you could have sold more newspapers. And so how do you figure out how many newspapers to order? And it's based on the ratio of the cost of understocking to the cost of overstocking plus understocking. And that ratio you want to set equal to the probability that you sell a certain quantity of newspapers. And so you have to create a prediction. You need to create a forecast of what is my probability of selling 80 newspapers today. And then what is the cost of overstocking and the cost of understocking. And from that, you figure out exactly how many newspapers to buy. You jive with that? How might you use this in, you know what, I don't have a thought bubble, but I'm going to use one anyway. How might you use this in a healthcare context? Yeah, absolutely. And that's actually one of the really interesting things in a hospital, that right now most hospital managers think we have this many active beds, so we have to keep them all active all the time, unless one breaks or not. And they don't think about flexible staffing on a daily basis. They don't think about, let's look at how many scheduled admissions we have versus how many predicted emergency department admissions, and let's not, keep one of our beds open. And that leads to electricity costs. That leads to staffing costs, cleaning costs. So what makes that difficult compared to a newspaper problem? If you're a newspaper vendor, you kind of know the cost of overstocking and understocking. In a hospital, what is the cost of having too many beds operational versus the cost of having too few beds operational? That's a much harder problem to quantify. And the issue right now is that not enough people have thought about it. If this was the beginning of the semester, I would have made you, asked one of you to do that as a project. But maybe if somehow I end up teaching this class next semester, somebody will work on that. So let's use forecasting and inventory management. Have you guys done inventory models, the EOQ model and stuff like that? Awesome. So if, let's say, you are ordering big chunks of supplies, let's say you are a hospital and you need to order, however many gauzes to last you 10 months. What you do is you have this huge, and you can't order them constantly. You can't order like 4 a day. You have to order a big chunk from your supplier. What they have is, I'm standing right in front of it, these models that say, all right, based on how many you expect to use, you order some big chunk, and then you use it over the course of time, and you order another big chunk, and you use it over some time. And that will then give you sort of the optimal. You can calculate what is this optimal chunk given the amount of time that I want to use and the amount of products that I expect to use over the course of that time. Does that make sense? So the y-axis is how many gauzes you have right now, and it's slow, and then the x-axis is time. So you order a bunch, and then slowly over time it runs out, and you order some more, and slowly over time. And there is an equation for the optimal number, the optimal Q number you want to order, and it's based on this forecast of how many you're going to use over that L time period. Okay? Now the thing is that real life is not as clean as that other graph was. In reality, you're going to get very variable usage, right? Sometimes, maybe there was a bus accident, or maybe, God forbid, or maybe something else happens, or there's a gauze shortage. So you have to figure out exactly how many to order and how much you expect to use. And sometimes you might order just the right amount, even though there's a whole mess in terms of how it's being used. But sometimes you might not order enough, and that something happened that you really needed way more gauzes that year. And so there's more that has to be done in terms of making these predictions, and that's when you add a safety stock. And you realize that predictions are never perfect. If we had a perfect prediction, we would be able to use this system. But it never works out that way. We end up doing here. And then there are more equations for figuring out the optimal amount of safety stock to have. Now the thing is, hospitals rarely use this. And most places rarely use this optimal sort of safety stock. And so you end up with huge stocks of one thing and not enough stocks of another. And you end up with all this sort of running around trying to figure out, where do we get our gauzes, how quickly can we get more, and so on. And so you want to figure out that optimal amount, and how you predict it is the best. Then we get to another use is staffing emergency department beds, somewhat what we talked about. The bed is there. There's nothing you could do about it. But you have to turn the lights on. You have to have a staff member there. If it's there and a patient is waiting online, they're going to see a bed with a light off and say, well, why isn't that being staffed? So you get some, anger from patients as well. And so there are tools for figuring out how many beds, given a certain amount of patients that are going to need the bed, you can calculate how many beds you need. All right? And you've done some queuing theory? So having done some queuing theory, you know that given a certain arrival rate, you can figure out how many beds you need in order to have a 95% chance of keeping the waiting time under 2 hours. Right? Is that about, you did like the MM1, MMNQ? That arrival rate, though, is a forecast. Right? You know how many you got yesterday, but you don't know how many you're going to get today. Yeah?
The application of this in a real world setting, it would be easy to say that the arrival rate would be like kind of a steady more patients who come in at certain hours and more patients who, in the waiting room or emergency department can be very light in the middle of the day versus, the beginning or end. And how would you recommend kind of adjusting for that? Would you recommend doing kind of like the arrival rate per hour in 10-minute chunks and in half-hour chunks?
So there's the optimal answer and there's the realistic answer. Realistically, nurses and other employees and doctors work in 8-hour shifts, right? So you can't really schedule them on a half-hour thing unless you were to start like one working at 7 and then the next person starts at 7:30 and then so on. So you have limitations in terms of what you can do. And you want to know those limitations before you start your analysis and say, all right, union says people work from 7 to 4:30 or whatever it is, so I have to work on that. And so then based on that reality of the situation, then you can decide where you want to go. This model actually right here breaks it down by an hourly basis. How many beds do we need operational per hour in the emergency department? And this was written by Linda Green. And what they did was, even though queuing models require a steady state level of arrival rates, what they did was kind of say, well, we're assuming it's close to steady state even though it's changing throughout the day, and so this is about what we need. And so I would recommend an hourly basis. In my work in the past, what I did was I used computer simulations usually rather than the mathematical models. And with a computer simulation, you could sort of play around with it. So you say, if I schedule it by the hour, what's my result? And then if I schedule it by 3 or 4 hours, what's my result? Are they close? If they're close, then let me recommend the 4-hour blocks because that's going to be more sort of realistic. Is that helpful? Cool. So forecasting is a piece of queuing models, right? You need to figure out what your arrival rate is going to be. And so here's 3 different time frames of forecasting in the emergency department. What you have here, this is the real data from VA Boston. So what you have here is the hourly arrival rates on average over the course of, I think this was over 2 years, average over 2 years. Yes?
This is all based on observation?
Correct. So this was, well, based on historical data. I didn't sit there with a stopwatch. They don't, they pay me too much to do that. I sit in front of a computer. So this is the hourly arrival rate. And what you could see is exactly what, I didn't catch your name. What was your name? Daniel. What Daniel suggested is that there's a very clear trend in terms of evening arrivals and midday arrivals. And you will see this exact same trend at every emergency department you ever look at. I mean, you could just change the name and it pretty much ends up the same. And so, maybe with a little bit more smoothing and stuff like that. And so, this is coming. But there's going to be variability. Some days, while noon on average tends to be the biggest, maybe one day you're going to get really low arrivals at noon. And maybe other days you'll get a lot at midnight. Who knows? And so forecasting can look at those sort of many terms. And so in the long term, you see that in general at VA Boston, the arrival rates are going up. More people are using the emergency department. So while I know that there's all this variability during the day, and I can decide, all right, how many beds do I want operational at that time, I can use the long-term trend to say, how many beds do I want to build for? And I just turn some of them off and on, depending on what's coming that day. Does that make sense? There's also seasonal variability, and this might be for staffing. Maybe during a certain time of the year, it tends to peak during the summer and drop off in the winter in terms of arrivals. And so maybe during the summer, I'd want more nurses in the emergency department, but during the winter, I can stick them in the ICU or wherever else I can use them. And the better these predictions are, the more money you can save. Because if I know I can send a nurse from the emergency department to the CCU, that might save me from having to hire a second nurse. Okay? And again, if we look higher up and on the public health sort of example, you might say, well, given how the trend of the flu virus, you don't need to staff flu vaccine givers throughout the country during the summer. People just don't really get the flu that much during the summer. You can correct me if I'm wrong. But during the winter, you might want that. And so you can figure out, all right, what do we need people for during the summer? And can we forecast that and figure out how to optimally sort of shift our staff around? So I just kind of answered these questions, but let's talk about them a little bit. What other kind of examples can you think of that's something that you'd want to predict over a long-term trend? In public health, in hospitals, in life, anything. Quality. So you want to predict how the quality of your hospital is going to be changing over time?
Quality of care, if it changes like seasonally.
Mm-hmm. That's a great example. And so that's a really cool example of looking at historic data, saying how did the quality of care change over time, and we can expect that to happen again. And then you'd have to drill back down and say, all right, what caused that variation? Was it a seasonal thing? You know, is it because the residents changed midterm? And that's a true issue, actually. In hospitals, you can look at the time frame of when the residents changed, and you see a decrease in quality. And then it slowly gets better, and then it's classic. And so they've started to sort of overlap a little bit. Great. We'll go in the back first.
Readmission rates?
Readmission rates. That is, if you look at the healthcare use of prediction right now, readmission rates, if you Google Scholar, forecasting in healthcare, readmission rates is going to be the #1 thing to come up. Exactly. And there's two ways to look at it. How do we, if we just assume our readmission rates are constant, let's forecast what they're going to be and prepare for that in terms of demand? Or what are the traits of a patient that causes them to need more care so that we can avoid that readmission? And you could create a prediction model that this person has a likelihood of readmission of 60% or something like that. Good.
Actually, the question.
Sure.
Whenever there's a natural disaster or some sort of massive emergency and there are a lot of patients coming in, is there a way that there's a plan for that or pre-prepared, I don't know, guidelines or something that
Yeah.
the hospital goes by?
That's a great question. There are some hospitals that are prepared for it. I would wager that BMC is prepared for it. I would wager that some other hospitals are less, small community hospitals are probably less prepared for it, depending on their management. There are schemes out there in terms of optimal preparedness. Perfect example is Newton Wellesley Hospital over in Newton Wellesley. They actually have a bay that is meant for like storage, but it has showers and hookups for beds and electricity, so that if there was a major emergency, they would be able to quickly turn it into like a 10-bed ward, like instantly, in preparation for that. And it's cheap. It's cheap to set up the bay, and then you have some storage area, and then you're ready to go. It's hard to forecast one-off events, right? Unless you look at a long time. So you say, all right, we know that a one-off event tends to happen once every 20 to 30 years. And so what is the value of investing in that? And you can figure out, all right, well, let's invest in. Now, the issue is when we get to forecasting, when you get to models and queuing models and all that, people tend to use averages, right? So if you say one event happens every 30 years and say 30 people come in due to that bus accident, so let's build one bed. That's not good use of forecasting because you took the average over the whole thing and said, well, on average it ends up, but when the 30-bed accident happened, you don't have the beds. And so that's where forecasting really comes in with those sort of emergencies, is not, how do we prepare for that one big event? Yeah.
Predicting when the hospital can get paid for the different reimbursement groups.
Yes.
You know how financially you're going to be doing over the course of a month or financial quarter.
Absolutely. I mean, all of this, I should say most of the content in forecasting was originally developed for forecasting profits and and expenditures and things like that. And exactly, hospitals have to do that more and more. Fortunately, working for the VA, I get to avoid some of the money aspects of it. So I don't have any awesome examples, but you clearly get the thought. Any others? Cool. So another use of prediction that I kind of got at with the readmissions thing when it was brought up is the use of prediction for differential diagnosis. Has anyone rounded with like medical residents or watched a medical education session? So I had a great time once. I spent a couple of weeks rounding with some residents and watching them get trained to become doctors. And literally what they do is they get these scenarios where they then have to run through all the possibilities of, given that the patient had this symptom and this test result, what is it that they might have? And they list out all the things they might have. And then they get told at the end what that patient actually had. Or they get told, these are the symptoms. What test would you get? I get these tests. These are the results. All right, now with those results, what is your diagnosis? What more tests can you get? And literally, they're building probability models in their head. Given that somebody has a fever, what is the probability that it's the flu? What is the probability that it's a cold? And then I might ask you, if someone comes in with a fever and they're 16 years old, what's the probability that it's the flu? Versus if they come in and they're 88 years old. And so these factors, these little one-off things, can influence your mental model of probability. And we create mathematical models to basically represent that mental model that the doctors are building. Does that make sense? And so in a way, a differential diagnosis is a horribly imperfect prediction model. But it's gotten us this far, so I'm happy with it. I'm running out of time already. That's okay. Is everyone okay with this pace? I mean, do people really care about what my research ends up? I can run through it at the end. But this is...
One of the assigned readings for the
was my research. You all know what I did. I'm sorry. So we'll skip triage. You get the point. So now let's talk about the different kind of variables that go into a prediction. You have exogenous variables, which are environmental. You have no control over them, versus endogenous variables, which are inherent to your system. Okay? So, for example, there is the endogenous variable of your community, right? If you run a hospital down in Fort Lauderdale, Florida, you know that you are going to have a certain readmission rate because somebody over the age of 80 is just going to keep on coming to the hospital a certain amount of times, okay? There's nothing you can really do about that sometimes. Maybe for some of the things you can, but for the most part, you're going to get a lot of visits. But if you are dealing, for example, with a mixed population, like here at VMC, you might be able to control how many readmissions you are going to get by having education programs, primary care, sort of reach out, hot spotting, and things like that. And those are endogenous variables. Those are things that are inherent to your system that you can control. Okay? So the way people tend to use exogenous versus endogenous is if you have two hospitals next to one another, they're going to share the same exogenous variables, but they might not share the same endogenous variables, right? So like Partners Healthcare might do a really good job reaching out to the community and preventing readmissions, while Hallmark Healthcare has the same community, but maybe doesn't reach out as much. I'm not actually saying that either one does anything. I'm just using that as an example. I know nothing about either of those systems, other than I've been to them. So let's see. These are just a bunch of examples, but let's move on from this. So in the guts of a prediction, has anyone done a forecasting model? Have they done a forecasting model in the class?
A little comparison of expert opinion versus basic probability, right? And so a little.
Oh, that's my game. I love that.
I know.
Okay, so there are a couple of different ways that you can do predictions. Expert opinion, I believe, is one of the most underused examples of prediction. Expert opinion is used all the time in terms of predicting a diagnosis. That's medical. But expert opinion in terms of whether someone's going to get admitted, whether they're going to get discharged that day. When nurses are talking, one of the big improvements to hospital flow right now that's sort of being used in different hospitals is to have a meeting at the beginning of the day where the head nurses of each ward go over their current patient population and say, I expect this person to be discharged today, this person to be discharged today. And that gives you an idea of how many beds you're going to have available halfway through the day. And that allows hospital managers to make better decisions in terms of flow, in terms of transferring patients out, canceling elective surgeries, and so on. That's an expert opinion example. Simple probability is, I would say it is probably the most used version of prediction, and rightfully so. It's easy and gets you most of the way there most of the time. Okay? So you didn't do a Bayes theorem. So Bayes theorem uses comparative probabilities of certain events and treats every variable as its own sort of independent variable. So the fact that somebody comes in to the hospital and they're 65 with chest pain, I would say your probability of admission is the combination of the probability of being admitted given that you're 65 and the probability of being admitted given that you have chest pain. Okay? But in reality, someone coming in 65 with chest pain and overweight makes their, kind of exponentially increases their likelihood of admission because chances are it's something very serious. And so other models try to take that into account. Neural networks, which I'm certainly not an expert in, and Bayesian belief networks are sort of more complex combinations of different probabilities, and they try to model the human mind. That's why they're called neural networks. Classification trees do exactly that. They sort of put things in different sort of classification categories and groups and assign probabilities based on that. Support vector machines I actually know nothing about. Regression, most of you have probably done some regression in your life. You did it in like 6th grade trigonometry, or maybe 8th grade trigonometry. I don't remember when I took trigonometry. And there's a couple of ways to do it. There's linear and logistic is the real popular regressions. And then there's fuzzy logic, which again I'm not too good at. So this is where what I was told, I went and talked to the foremost mind on artificial intelligence at MIT. I mean, the guy is brilliant and published in so many journals. I mean, he like invented artificial intelligence. And I said, I was creating a model to predict admissions. And he said, okay, try expert opinion, naive Bayes, and linear regression. If they don't get you where you want to go, then come back and we could work on something harder. And all three of those simple models got me somewhere. And the linear regression ended up being the best, which you know because you read the article. So there's a science to these different ones, and a lot of people are trying to make them better, but often simple prediction is the way to go. And so all of you, I have faith that all of you are capable of doing at least expert opinion, Bayes, and regression. Okay? And you could do them all in like Excel. Okay? So this is, we don't need to give it, there's a ton of examples of people using prediction in healthcare. This is specifically a chart I made for my dissertation, which shows who made predictions in emergency departments about actually getting admitted. And so I give a couple of different examples of people using clinical versus statistical and so on. So that leads me to my work. Do we have any questions? No? All right, so I'm going to give you the last 6.5 years of my life in about 10 minutes. All right? Cool. I'm used to doing that. They say you're ready to have a PhD when you can explain your entire PhD in one sentence. All right? So my one sentence is that I predicted whether patients coming into an emergency department would need admission to the hospital, and then figured out how to best share that information with the hospital to improve flow throughout the system. That was my 6.5 years. Did that make sense? I earned my PhD. Thank you, everyone. Where's my robe? Okay. So in a emergency department, quality is connected to flow. If you look at anything published in emergency department flow and quality, everything is time measures. How quickly you get a patient to the doctor, how quickly you get them to a bed, how quickly you get them to an ECG, a balloon inflation, severe pain assessment, everything is time. We assume that when they get to the doctor and nurse that the doctor and nurse are going to do the correct thing. Saying otherwise is probably more your realm than mine. studying whether, quality and what's causing that. I just say let's get them to the person. So the inability, and all the most recent literature has said that the inability to get a patient out of their emergency department bed and into the hospital when they need admission is the biggest bottleneck in the emergency department, because those people are holding up beds, and a new patient needs a bed. They're sitting in the waiting room, and they can't get it because that patient's waiting, the other patient's waiting to get into the hospital. Okay? And so a lot of focus now has been placed on reducing that time between the emergency department and the inpatient unit. So what I suggested as part of my research was that we can predict whether a patient needs admission to the hospital when they arrive before they've been seen by any provider. We can predict whether they need admission to the hospital. And then we can use that, on average, 3.5 hours of emergency department treatment time in order to actually start preparing their bed in the inpatient unit. And this way, when they're done with their treatment, the bed's ready to go and they just move on. Pretty simple concept. And it's amazing how many people I had to sell it to, even though it was that simple. So the great thing about the current system is everything is deterministic. A patient gets admitted to the hospital, nurses start, or bed coordinators start doing their thing in the hospital only when a patient has been designated for admission. Everything is certain. Okay? But in this sort of prediction-based system, you add uncertainty. I'm assigning a probability that that patient is going to get admitted. And if I send that probability up to the hospital and they start acting upon it, and that patient doesn't end up needing admission, they're going to get very angry with me. All right? And so how you use this forecast, this prediction, is very important. How you make it, how you operationalize it. So we'll skip this slide. Research questions were, how do I predict? Given the predictions, how do I use them to improve flow? And then how do I use them at other hospitals? So I started with the expert opinion, and so I have had multiple health systems researchers say to me that they cannot imagine a carrot or stick that would get nurses to cooperate with this kind of research. Okay? And in general, that's true. And the trick to getting them to cooperate, not cooperate, but to actually be excited and participate, is to, before you ask them to do anything, spend about 1.5 years at their flow meetings and offer suggestions, help them do some of their own number crunching and all that, so that when it's time for you to request help, they're totally, your friend and ready to go for it. So rule number 1 about working in health systems is to be involved and not just try to academically look at things and then ask people when you need stuff. So what I had them do, or what they were excited to do, was every time a patient came into the emergency department, the triage nurse would actually check off how likely it was that that patient would get admitted. Okay, in a 0 to 4%, 5 to 24%, and so on. I added the percents because my professors really wanted me to. In reality, the sort of qualitative, likely, definitely not sort of stuff is more valuable to the nurses. I also asked them to predict how long the patient's going to spend in the emergency department. That didn't go as well, but the actual prediction of admission went really well. So I chose a whole bunch of predictive, so that's the expert opinion. Then in terms of mathematical prediction, I looked at the database for the hospital and figured out what traits that I can pull out. And I ended up selecting 6 traits. One was whether they were sent to fast track or the regular emergency room, whether they, what their primary complaint was, what their age was, how they arrived, stretcher, wheelchair, or ambulatory, and what their acuity level was, which is actually an ESI level of 1 to 5. I need to update these slides. So then what I did was, in order to do this mathematically, forecasting, if you know what you're doing, if you have the mathematical tools, the computer programs, actually making your forecasting model takes maybe an hour. Okay? Maybe. And that's for all the coding and figuring it out and proving it. What takes forever is data collection and data processing. All right? I would say the first 1.5 years to 2 years of my PhD was collecting this data and processing it. Okay? So, for example, Excel can calculate the probability of getting admitted given that you have chest pain. If I have coded that correctly throughout. Anyone with chest pain, how many of them got admitted, how many of them didn't. The problem is when you look at records in the hospital, it will sometimes say CP, it'll sometimes say chest pain, it'll sometimes say chest pain but misspelled, it'll sometimes say chest pressure, and all these different things have to be gone through manually and coded. Okay? So that tends to be the reason why people don't use these forecasting. I'm celebrating forecasting as being an amazing way to get things done. But the reason it often doesn't get done is because of the amount of time required to actually make it happen. And another one of my projects at the VA is on a natural language processor. I'm not making it, I'm working with people to make it. That can actually look at the complaint data and categorize it without me having to do it manually. Yeah.
Did you have the opportunity to actually meet with the nurses and sit in on the meetings that you talked about?
Yes.
Okay.
Yeah.
What kind of things were they already doing to improve the flow?
So most, and looking back at it unsurprisingly, most of what they did were communication issues, right? So they might say, oh, well, when we have a patient with this kind of trait, are we calling the right people on the inpatient side to make sure that this admission happens properly, that we, when we have an issue, are we really noting it properly in the record so that when it gets shared, things like that. They're not thinking on like the whole system-wide, how do we model resources and stuff like that. But I've been sitting on that committee every Thursday for an hour for the last 5 years and continue to do so, even though my job does not require it. But it sort of just keeps me grounded and reminds me of the kind of issues that they think about. And when I'm ready to work on something, they'll still see me as a member of their group. Have any of you, did you guys learn Lean and Six Sigma and stuff like that? So they're trying to undertake a Lean Six Sigma approach. And so I'm helping them with like huddle boards and PDSA sort of methods and continuous improvement now. That's how I'm helping them. So you code all of this. This is my 85 codes that I was able to break down my 30,000 data points into. So that's really not bad. And then you use these methods that we talked about, naive Bayes and linear regression. And here's the linear regression. And this is how they performed. So just to read this graph to you, based on the categories that I set up in the expert opinion, a patient put in that category, what is the probability of all the patients being put in that category being admitted? So of all the patients put in the 0 to 4%, what is the probability that they got admitted? Okay? And of all the patients put 95 to 100%, what percentage of them got admitted? Does that make sense? So you'd want it, and these blocks, these lines represent the category. And so you'd want your lines to go almost directly through, my data lines to go almost directly through these bar lines, okay? And so what you could see is expert opinion, nurses are really good at predicting who will not get admitted. They are less good at predicting who will get admitted, okay? While naive Bayes predicts pretty well on the low end through middle end, but then drops off when you're predicting who will get admitted. And then the linear regression that I used did a very good job predicting throughout all of it. So it was able to say who won't get admitted, who might get admitted, and who will get admitted. With limited counts. It is better at the low end, but it does okay up there. So then the question comes, how do you use it? Right? The forecast is interesting, but you always have to be thinking about what do I use it for? And that should go back and influence how you do the forecasts. And we talked earlier about the, and I'm just going to call it quits with this description. We talked earlier about the news vendor model, the idea that you have to figure out how many newspapers to order by balancing the cost of overstocking versus understocking. What we could do with a prediction on a patient is say, all right, they have a 70% chance of being admitted, given the cost of getting everyone together to open up a bed versus the cost of not getting a bed open. What probability threshold do we want to use in order to get everyone moving? Do we wait until I get an 80%? Do we wait until I get a 10%? Something like that. And so what I ended up saying was actually we can do better by adding probabilities together. So it's called risk pooling. So when you get more things of similar risks together, you can perform better. And so what I did was I added patients up. So of the 13 patients in the emergency department, add all of their probability of admissions together, and then say to the hospital, we need about 6 beds. Okay? So if you have 2 patients of 50% admission, probability, that means tell the hospital you need to open up 1 bed. Okay? While if, let's say, and that also is cool because it allows you to use the subtlety of 49% versus 50%. So if I had a cutoff of 50%, only admit patients who have the 50% prediction, those patients who had a 49% prediction would not get used by the hospital. When in reality, that's pretty close to the 50%. Okay? And so by adding, you get to actually really use that risk pooling to your benefit. And so that was a big aha moment for me and so on. So it worked really well, and this is the data that shows that, and you've read about it, so I won't go into it too much further. You probably did not read about the fact that I did it at 4 hospitals in total. I did it for VA Boston, VA Manhattan, Newton Wellesley, and UMass Memorial. So they're very different size hospitals, and my method worked well at all of them using the linear regression. Again, this is that categorical data, but now in terms of 0 to 10 and 10 to 20, because I'm not using the expert opinion anymore, so I don't have to fit it into those categories. So, and again, this is all saying it worked well, believe me. And then I created a simulation model to actually show how the hospital uses the predictions. And what I did was I modeled a doctor's priority and said, like, when you reach a certain threshold in the emergency department, start to emphasize discharges, while when you're under that threshold, stay emphasizing treatment. And so it models how a doctor thinks. I don't tell the doctors what to do, I just affect their priorities. And that ended up leading to some great improvements in flow. I then actually, again, because I was part of the team, I was able to implement this live at the hospital at VA Boston. And when a patient came in, we actually assigned them a probability of admission, and then we would share that total prediction with the rest of the hospital by displaying this on the home page. So anytime anyone opened up Internet Explorer, they would see the current predicted bed demand. And I was able to run that for 2 weeks. There were no quantitative benefits, but 2 weeks really isn't enough time to show anything. But then I got to do a bunch of interviews to figure out how doctors would use these forecasts, what they mean, how valuable they are. And since you are all going to go home and put articles by me on your RSS feed, when I finally publish these, you will be able to read them and be totally stoked for me. That's in closing, that's it. Operations decisions are key to saving money. Forecasting is the way to do it. You can improve quality, you can improve costs, but forecasts are inherently wrong. Okay? Every forecast is going to, at some point, let you down. And so operations management in healthcare is about managing those forecasts such that they will not let you down too hard and that you can get the most out of them. And the last point that I sort of said a whole bunch of times is don't waste time on the forecast unless you've thought about how you want to use it. Think about the different models that we've talked about. Think about how this forecast can be valuable to you, and then go back and do the forecast. If expert opinion is enough, do expert opinion. It's simple. If you need something more accurate, more precise, then maybe you need to talk to my friend over at MIT. So that's it. Thank you all for your time.
Any
Done.
closing questions before we wrap up?
Yeah.
So you said based on the forecast that you were able to implement some of the things that you wanted.
Mm-hmm.
It's not that reliable. So I was wondering how often you go back to the forecast, or do you concurrently keep forecasting to see if you're being able to meet that demand, or have any progress in terms of what you're implementing?
Ideally, I would. So implementing my forecast required the nurses actually to enter extra data into a parallel computer system that I had set up. Yeah. So I only got permission to run it for the 2 weeks, because unless you can prove that the extra work is going to lead to better quality, they won't give you permission to do it for a long term. If I had it for a longer term, and once I get the natural language processor and all of it being automated, then I would start to do more quality checking as I was going and editing of the prediction. Really good prediction would actually include sort of steps in the emergency department treatment. So when the patient got admitted, I would assign their original probability based on their triage information. But then once they get a test result, a blood test, maybe that'll increase their probability or decrease it. So over the course of their treatment, I'd be able to sort of update it. And that's sort of a long term. When I do that, I'm going to package it and sell it, and then this building will be named after me. But you're right. It's an important thing to check it and to update it. Did that, by the way, answer? That was good? Great.
Just about the factors that you picked or the variables that you inputted. Could you go over again how you picked those specific ones and if all of them were actually necessary throughout or if you were able to eliminate some of them?
It's a great question. I did eliminate a bunch of them. How I picked them was two ways. One, to keep my research advisors happy and do some interviews and get the sort of proof from nurses that these are valuable variables. But in reality, the way I picked them is that's what was collected. Like you have to go with the realistic sort of, unless you're willing to put in the time to collect a lot of extra stuff. Whatever the computer system's been collecting for the last 4 years is what I'm going to use. So I, let's see. What I ended up using, does it say it here? Yep, this is the one I want. So I had these different, okay, this is what I want. So these are the different data I collected for each hospital. So you had what provider they were assigned to. That was an interesting one. Whether they were sent to fast track or to the emergency department, how they arrived at the hospital, and how sick they were. Okay? And each hospital tracked these differently. Some didn't track designation, and some didn't track mode of arrival. And so you make the model with what you can. And what I did was using statistics. You want to make sure that you have have you guys done any epidemiology? You have like p-values and stuff on statistics. So you want to make sure that the variable has a statistically significant impact on the prediction. And if it doesn't, you're supposed to take it out. The way I tend to do it is even if it's not statistically significant, if the model performs better with it in, then keep it in. Don't tell anyone. That's the data mining sort of way of doing it. But actually, in reality, every variable that I kept was also p-value significant, so it's okay. And so what ended up going into each model, at VA Boston, I used primary complaint, whether they were sent to fast track or emergency department, and mode of arrival. You should all be happy that the provider they were assigned to was not statistically significant for any of the hospitals, which is, warms the heart a little bit, because it means that they're at least somewhat consistent in their decision making. Mode of arrival, all the places that tracked it ended up using it in their model. And the one place that didn't track it didn't. So if I were to set this up as a running system at UMass Memorial, I would tell them start tracking mode of arrival because it was statistically significant in all the other hospitals. Urgency, interestingly enough, was significant at Newton Wellesley and at UMass, but not at VA Boston and VA Manhattan. And why is that? VA actually uses the ESI system differently a little bit than the other hospitals. And so somehow the way they implement that system, that urgency system, makes it less predictive than the way it was done at the private hospitals. So again, as I continue to do it here, I might say, let's look at how we calculate urgency because it might become valuable. Is that helpful?
Mm-hmm. Yeah.
Awesome. I
Thank
got a
you
clap.
so much.
Yes. Thank you.